Hi everyone, Dr. Simon Freilich here, consultant in clinical neurophysiology. Welcome back to the channel, and in this video I'm going to be talking about Piriformis Syndrome and deep gluteal syndrome. So this is actually going to comprise of two videos, and you'll hopefully understand why I've decided to split them up like this. In this first one I'm going to be talking about the broader issues involved, and then in the second one I'm going to be focusing more specifically on piriformis itself. But it's really important to watch both. So the first thing I'm going to say is that this is not a self-help video. There are plenty of self-help videos out there on how to try and manage this condition, how to improve the situation for yourself. However, this video is very much going to delve into the background, and hopefully you'll get more of an understanding as to what some of the controversies are with this condition or series of conditions, and hopefully come towards the right type of treatment that's best for you. The prevalence of this condition is actually quite uncertain. As everyone who follows this channel on a regular basis will know, this is very much an evidence-based channel, and I will always go back to basics. I will always go back to medical library and thoroughly research any of these topics. And it was quite apparent that there's a huge variation in the prevalences and how common this condition is being reported as. So sometimes it might be as low as a couple of percent of the population, sometimes it might be even 30–40%. And so when one has this kind of variance, one really has to start thinking about, how are these definitions made? How are these being reported? So there's quite a challenge in terms of trying to work out just how common this is and actually how well this is truly defined when the diagnosis is being made. And one of the fundamental things as well is that in terms of clinical practice, if the number of people having this condition are as high as 30–40%, then we shall be deluged in clinical practice with people with this condition. And however, that is definitely not the case, as we'll delve into a little bit more as this video continues. In terms of my own clinical practice, it's quite rare that I get asked this question, and when I am asked this question, it usually winds up being a lumbar radiculopathy or a problem with the hip joint. Now, I've got a separate video dealing with the various types of lumbar degeneration and processes that can occur and cause these kind of sciatic type symptoms, and you can see that by following the iCard over there. However, if one moves beyond my personal practice and has a look at the literature, one really should be concentrating on the radiology literature for this, because these are the primary group of people who have a look for this diagnosis from a diagnostic perspective. And if one has a look at their case series, and to make a worthwhile publication, one normally has to accumulate a sufficient number of patients to make a worthy series of publication, then actually one can see that the numbers of patients coming forth aren't that great. So I've put together a little table over here, and these are studies from the last couple of years, from 2016 onwards, and you can see the number of patients reported here are actually relatively small. So we've got 24 at the smallest and 116 at the largest, and if you look at the numbers of years that this was collated over and look at the number of cases per year, actually, roughly speaking, we've got about 17 or 18 cases per year at these rather large teaching hospitals, where one can assume that there's a relatively large population of people who may present there with such symptoms. And per year it isn't that great. The last one is actually quite interesting, with Lauren Fishman, who's quite an expert in this, and this was numbers reported from a particular private clinic, and they only had 28 in that year of publication at least. And so the overall numbers, even for someone who's quite an expert in this field, are actually relatively low. And so the overall point that I'm making is that this diagnosis, if the prevalence is so high, is something that is really being made in the community, because it's not reaching secondary care into the hospital settings, and also managed in the community as well without reaching us in secondary or even tertiary care. And so the people directly dealing with this will mainly be physiotherapists or family practitioners, or general practitioners as we call them here in the UK. And the mainstays of treatment will be rest, analgesia, and very specific stretching exercises. And so this is basically the same as conservative treatment for pretty much any musculoskeletal problem. And of course, some patients will fail on conservative therapy and will have a difficult time, and we'll delve a little bit more into that in the next video. But for the most part, this is going to be a soft tissue problem or a joint problem rather than a true nerve issue itself. And in fact, if you look at the material online here on YouTube in terms of self-help, you'll see that those stretching exercises are effectively putting people into what we know as the fair position, which is the flexed, adducted, internally rotated position. And basically, if you're going to be doing that repeatedly, you should be surely making the nerve dysfunction, if it's truly being irritated and damaged, worse if that was truly present. And so we effectively are having a situation which is fairly similar to thoracic outlet syndrome, which is another entirely different condition, which again is something which on the whole tends to be made in the community with physiotherapists for the largest group of those, and I've got another video just about that over there if you follow the iCard above. Basically, for the most part, it's a soft tissue problem in the rotator cuff of the shoulder, but in terms of the proportion who actually have a true nerve problem underlying it is actually vanishingly small, and I suspect that the same is the case here with Piriformis syndrome, that for the majority of patients this is really a soft tissue issue rather than a true nerve impingement with actual damage to the nerve itself. If we take it another step forward and we consider the radiology findings in those who actually do make it to secondary care, tertiary care in a hospital, and they are investigated, true piriformis of course does exist, but only occurs in about 25 to 30% of those who are imaged. And so the short of all of the above is that if you think that you have piriformis syndrome and you've had this diagnosed out in the community, the likelihood is actually you don't have it. So then the next question is well, what condition do I have then? I've got this pain over here in my buttocks, it's radiating down the back of my thigh, I can't sit for very long, very, very uncomfortable. So, you know, what's going on with me? That's a very reasonable question. So the first assumptions that one has to make is that one's actually cleared the lumbosacral spine, that there aren't any degenerative processes occurring over there, and that there aren't any degenerative processes of the hip itself. Now, even saying that might be controversial to some people who just like to see this as a positive diagnosis rather than coming at it from a negative diagnosis, excluding other causes. Obviously, we would like to try and sort of get straight into that as a diagnosis, but common things are common, super common things are super common, and you know, back problems and hip joint problems are by far the commonest thing. And so it's actually better to think of this, if one has excluded that, as a group of different syndromes known as deep gluteal syndrome, of which piriformis syndrome is one of a number of conditions. And so let's now have a look a little bit at the anatomy of the structures here, and hopefully we can get more of an understanding as to what might the alternatives be and what might be causing those alternatives. First of all, we have got the sciatic nerve, and of course it relates itself very much to the actual hip. It originates from the Greek term relating to the hip, and you can see over here that the nerve roots come out, and we'll look at that in a little bit more detail right now. And they descend downwards from L4 to S3 from their little spaces in between the bones, the foramina, and they come in front of a muscle called the piriformis muscle, which isn't the only show in town. It also has ligaments and tendons around it too, as together with other muscles. Now let's look at it from behind, and here's the behind view. So this is a piriformis muscle, and beneath it we have a number of external rotators. So we have the superior glomerulus, the obturator internus, and the inferior glomerulus, all beneath it. And then the actual sciatic nerve comes between the piriformis muscle, which it's in front of, and then it moves backwards behind these other external rotators over here. Then we have the gluteal space, so that's the subgluteal space. So the gluteal space, where we have the gluteus minimus, we have the gluteus medius, and then of course the gluteus maximus, and now this is beginning to look a little bit more like a recognizable butt. So within the subgluteal space, there are a number of different differentials, different causes that might cause an identical syndrome to piriformis syndrome. One of the most interesting aspects or causes that's becoming increasingly recognized, particularly with endoscopic procedures, are fibrous bands, which can cause constrictions over the sciatic nerve and can certainly cause intense pain. One of the biggest misnomers, of course, with any nerve issue is that nerves tend to be an originator of pain, and for the most part they aren't, except when they become ischemic, which means that there's a lack of blood going to them, or if they become infiltrated. And so if you have an ischemic process, if you have a very tight band digging into the nerve itself, that will certainly cause pain, and that's certainly a very plausible explanation for many people's symptoms within this group of conditions. We have piriformis syndrome itself, and then we have various syndromes relating to the obturator internus, the glomellae, muscles, these external rotators, or to the quadratus femoris beneath. Of course, we have any issue relating to the gluteal muscles, and then we have the enthesopathies, where one has issues relating to the tendons or ligaments, where any of the following processes can occur. There can also be various fractures relating to the bones or apophysitis. This is problems relating to the actual growth plates themselves. So, having looked at all these differential causes and their anatomical structures, can you tell which cause is responsible just sitting at home? And the answer is no, you can't. You need to see an expert, because of all the different overlaps of all these different complex structures, all in a very similar and very complex space. And so one of the most common questions that I get asked on this channel is, well, who should I see? And I would actually recommend the most efficient way of moving forward is actually to see an orthopedic hip specialist, because they are best placed to move you forward with all of this. As I've said, most people will respond to a deep gluteal syndrome with conservative therapy, and that's clearly by the fact that so few wind up in hospital. For those who are finding that conservative therapy with rest, analgesia and appropriate physiotherapy stretching exercises aren't being helped, or if the symptoms are progressive or particularly painful, then obviously that should prompt more in-depth investigation in secondary care and proper medical evaluation. So in the next video, I'm going to speak more directly about piriformis syndrome itself. And in the meantime, I'll thank you for watching this video and looking forward to seeing you soon in the next one. All the very best, and please do continue to support the channel by liking, sharing, and of course, subscribing. Bye-bye.